Good afternoon, everybody. Thank you for being here in another community chats. Today, we're going to be talking about myths and truths about diabetes. November is Diabetes Month, so we can't get enough of diabetes and share some knowledge because a lot of people out there have diabetes. It's said that 1 in 10 people have diabetes, and if they are seniors, 1 in 3. So think about your neighbors, think about your family, and I'm sure there is always somebody that you know that has diabetes. So that's the reason why it's so important to create more awareness about diabetes and especially how to treat it. But there are also a lot of beliefs about diabetes and a lot of misconceptions, but some of them might be true. Who knows? So that's why we have 3 experts here that would introduce themselves in a minute. And just to get this conversation started, and please, to all of our attendees, just a reminder, there is a Q&A box, there is a chat box, so if you have any questions about this topic, just put it there, and I'll be happy to read it to our presenters. So let's start with you, Denise, because you're at the top of my screen. Can you introduce yourself?
Yeah, absolutely. Thank you, Sandra. My name is Denise Roma, and I am a registered dietitian nutritionist and also a certified diabetes care and education specialist. I have been here at Montefiore Nyack Hospital about 13 years, and I see people who have diabetes, whether it's type 1, type 2, gestational. I also work with people who have pre-diabetes and teach a class called the Diabetes Prevention Program. I facilitate a support group here at the hospital for people with type 2 diabetes, which is once a month. And, you know, I am certainly passionate about diabetes. I do feel knowledge is power. I think the more we know about it, the better people will do in taking care of themselves. So I'm excited to be part of this panel today with all of these wonderful speakers. And with that, I will pass on, I think, to Aeneas, who is right below me there on the screen.
There you go, Hollywood Square. Good afternoon, everyone. My name is Aeneas Suarez. I'm a registered nurse, and I have been here at Montefiore for the last 6 months in the capacity of inpatient diabetes educator. I've been at Montefiore for my entire career as a nurse, almost 15 years, and there is so much that I can talk about diabetes. Before becoming a diabetes educator, I was a case manager, so I touch base with all those involved in the patient care related to diabetes. And today, I'm glad to be here for us to demystify a lot of misconceptions there about diabetes. So again, and you can always reach out to me, to our department, if you have friends, families, and even patients that need diabetes education there. So it's a pleasure to be here.
Thank you. Last but absolutely not least, Lorena Drago.
Hello, and thank you for inviting me. I am Lorena Drago. I am a registered dietitian and a certified diabetes care and education specialist. I am a blogger, I'm a writer. I write a lot about diabetes and different aspects about diabetes management, about food, how food fits into diabetes management. I write also about how to manage diabetes into different aspects, but mostly about food, which is, there is a lot of myths about different types of foods and how to manage diabetes. And I know we get a lot of different information about foods. So I do enjoy that a lot. I am a speaker, and I always love to communicate with individuals about diabetes, pre-diabetes, whether it's type 1 or type 2 diabetes. And I also work with patients. So I'm very happy to be here today to engage in conversation.
Well, Lorena might be very happy, but we are extremely happy to have Lorena because she's just being too humble. To say the least, if we are certified diabetes educator, care and educators specialists, we've all learned from Lorena at one point or another. She's always a speaker in diabetes conferences. She's written 2 books about how to take care of diabetes. And last but not least, this year she won the Diabetes of Educator of the Year award for the United States, not just for the state. I have one for the state, but she won the whole United States Diabetes Educator of the Year award by the Association of Diabetes Care and Education Specialists.
Thank you.
So she's a legend and a good friend, and I'm so excited that she's here with us today. So thank you, Lorena. Okay, so let's get this started. Again, lots of people talk about a lot of things about diabetes, and you know, when you are with patients, we can hear a lot of things that people say about diabetes. So let's start with you, Lorena. What's that idea that you most currently hear that people believe that might not be true?
I'm going to talk about insulin because I have been doing a special on insulin, and to dismiss a lot of ideas about it. So I am a storyteller, so you're going to have to excuse because I love stories. So one time I was doing a supermarket tour, and there was a young man who was diagnosed with diabetes, and he came on a tour with his girlfriend. He had been prescribed insulin as part of his therapy, and he said to me that he was not going to use insulin. My follow-up question was, what concerns you about using insulin? And he said that he did not want to become addicted. My follow-up question was, what have you heard about insulin addiction? And he said that I am afraid that once I start injecting insulin, I will not be able to live without it. And I have never used drugs, and I don't want to start using drugs. And I am not going to inject any drugs. So based on his answer, I immediately put 2 and 2 together that the method of using the medication, how the medication was used, which was what he assumed was intravenously, was the cause of addiction. Then the follow-up question was, have you taken any other medication, whether it was for diabetes or anything else? And the answer was yes. And it was through oral administration, mostly in form of a pill and a liquid. Did I ask, was that a concern to you? And he said no. So many times asking follow-up questions, and it was the route of administration that was a concern, more so than how it was administered. And allaying the concerns that insulin was not an intravenous medication, that it was subdermal, and that then became less of a concern, and that it had to be used daily. It was because insulin, his body produced insulin like all of our bodies until the body did not produce enough insulin. So the insulin was replacing a function that the body no longer was doing. So we started to talk about my glasses, which I wear daily. So I asked him if he felt that I was addicted to my glasses, because the first thing I do in the morning is put on these glasses, and the last thing I do is take them off. And I cannot live without my glasses. I have to do it daily. So he smiled and he said, no, he didn't think I was addicted to it. But I could not live without my glasses, whether it was these glasses or in the past, I used to wear contacts, which I can't anymore. But I could not, this is replacing what my eyes can no longer do. So insulin was very similar, but this was external, and insulin production is internal. So having conversations and explaining many times allays the fear, provides the understanding that individuals do not have. And when that occurs, then someone can make a decision based on the new knowledge or knowledge and skills. Once someone is shown how insulin is used, whether it is via a pump or just simple with a syringe and a vial. So that was one of the many times that there has been a myth when it comes to insulin administration.
Sandra, we can't hear you.
You're muted.
I was saying you hit the nail on the head, because there are a lot of misconceptions about insulin as well. One of them, again, myth or truth, is if you start using insulin, you're gonna gain a lot of weight. And you know, especially that belly weight, like your belly is gonna grow. So do you wanna say something about it, Lorena?
Yes, I think that misconception also occurs because when individuals are diagnosed with diabetes, there is weight loss, and that it's very common. When insulin is administered and blood glucose now is in range, then individuals now have and target blood glucose, and then they are able to normalize their weight. And by then they are going to increase their weight, therefore they're going to gain weight. And once they are able to start carb counting, they are able to understand how they're going to be able to eat and then use the insulin. They are going to start being able to be a little bit more comfortable eating a little bit more. So they might be able to gain weight. So many times the key here is to understand that you have to be a little bit more careful once you start to use insulin and other medications, that you need to manage your meal plan, because otherwise, if you are not going to manage your meal plan and you're going to eat when you are no longer hungry, but because now you have found a certain freedom, there might be weight gain. If you're no longer hungry, but you're eating besides, beyond your hunger cues, there might be weight gain. But if you're eating within your hunger cues and you're already full and you stop eating, then you might just regain the weight that you lost when you were hyperglycemic, and then you're going to be okay. So I think it's just a matter of understanding your hunger cues and not going beyond that.
Mhm. Thank you, Lorena. Denise.
Yeah, I did want to add, since we are talking about insulin, and Lorena, you brought up some very interesting points that I think as diabetes educators, we all come up against, and that is asking questions of the person that we're talking with. And when you brought up insulin, I remember quite a few stories of patients that I have met who have had type 2 diabetes for a long time, and suddenly the conversation has come up that they needed to start insulin. And by the time they're meeting, with me as the diabetes educator, I'm hearing resistance, and, they don't want to take the insulin. And not until you ask enough questions and find out why, to your point, because I've had many patients say to me that I don't want to take insulin because it causes amputations. And when I ask a few more questions, I've learned from some of these people that their grandmother had type 2 diabetes, and they remember her taking insulin, and they were young at the time. And they remember soon after she started insulin, she had something amputated. And so the memory that stayed with that person is that insulin causes amputations. And unless we ask that question, how are we going to know how to address that concern? Certainly, if any of us had seen that and believed that was our perception, why would we ever agree to start insulin, right? So, when I ask more questions, and then as educators, here's our opportunity to explain to people, give some knowledge and explain that grandma probably had type 2 diabetes for 20 years, and her pancreas was no longer making insulin. And those complications were happening over 20 years. They didn't happen when she started insulin. And so, perhaps the association seemed that way, start insulin, amputation, but in fact, it was a lack of control of blood sugars over 20 years. And so I think if we teach people the most important things in diabetes self-care is controlling blood sugars, and maybe perhaps starting insulin sooner as needed, it's exactly the opposite. We can, in fact, prevent amputations by intervening and perhaps starting insulin sooner and controlling those blood sugars sooner. And so, you see that aha look on people's face once they become empowered with knowledge and learning how these things work. Mm-hmm. So, yeah, you reminded me of that, Lorena.
Yeah, and Denise, I have to add, like, I've heard that, but I've also heard about blindness and even death. Like, people are like, no, if I'm being prescribed the insulin, it's because I'm at the end of life. My diabetes has taken over, and there is nothing else I can do. And talking about that, diabetes taking over, what do you guys think? And as you see patients in the hospital where they get first diagnosed with diabetes oftentimes. So do they have that feeling like, oh, now it's the end of my life?
Right. And just recently, I saw a few patients that they had been newly diagnosed with diabetes type 2. And at first, I go in to see them where they understand. And they, first thing seems to be denial. No, I do not have it. Nobody told me. So while they are here, well, being taken care of, being treated for that condition. So before they are discharged, I go to see them again. It just happened recently. So that patient really was overwhelmed with emotions. How am I going to live? I have children, I have my busy life and my husband and my work and all that. She was completely overwhelmed. And I said, but I thought that you understood when the doctor gave you the diagnosis a few days ago. I said, no, but about my life, I have things to do. I'm not going to stop to do insulin 3-4 times a day. I'm not going to be breaking my finger. And she started crying. So it was a lot. It took me about 45 minutes just to let her vent, to see what her perception was about it, and little by little make her feeling more comfortable about the city. It's not a death sentence. I understand where you're coming from, that it was too much after 3 days. Now you report to me, no, what am I going to do when I get back home? I won't have the time to do any of this. It's going to disrupt my entire life, activities. It took quite a while. Depending on the patient, we have first to, allow them to express their feelings and help them to better cope with that diagnosis. You want to be able to teach much if she has or he has all those kind of emotions there. First, listen, little by little tell patient that it's not a death sentence, that you're not the first one, you're not going to be the last one. Diabetes has been there for quite a while, and people are living much longer, and they do not have to fear that diabetes is going to take over their life activities. So it took me a while, and she cried. And then you go with your, let's say, frame to, you see, let me tell you what I can help you with and this and that. Patient's not listening. So this was one of the cases this week that it was too much for that patient. So I said, well, we're going to deal one thing at a time. Let's see how you feel about diabetes. In the future, call me again. We're not gonna go any further because now for you to try to educate her all at once and all that, it's gonna just exacerbating the misperception, the myth that diabetes is a death sentence. So that's what it was in her mind. So deal with the emotions first. There are other cases that they say, okay, what do I need to do? I said, just follow the doctor's instructions. There is no cure, but there is management for that sugar out of control, your diabetes, nutrition, medication, and exercise. Let's see what you feel comfortable with, how you can add that to your diabetes care. So there are many ways to go, but that one was the highlight of the week that she thought, I'm going to die. I said, no, it's not a death sentence.
Thank you, Nes. And Lorena, we have a question from one of our attendees. Is the myth true that pre-diabetes turns into full-blown diabetes even though it's reversible?
What I know is that for many individuals, pre-diabetes may turn into diabetes in approximately 6 to 8 years, but it doesn't occur with every single person. Now, based on the diabetes prevention program, individuals that engaged in physical activity 150 minutes per week, and they experienced weight loss about 5 to 7% of their initial weight through a change in lifestyle. 58% of them experienced reversal compared to individuals that used metformin, which is a oral hypoglycemic agent. That was 38% of them. So it means that if someone has pre-diabetes, which means that their blood sugar is high but not high enough to be diagnosed as diabetes, and engaged in physical activity most days of the week, and they follow a healthy, nutrient-dense meal plan, 58% of those can reverse it back to what it's considered to be normal blood glucose sugar levels. So that is very good news. And there are many diabetes prevention programs, including one at Montefiore. So that would be a good way to start trying to do that type of prevention, because it has been replicated so many times with very good results. So I would say just do that, because it has had excellent results.
Denise, I'm sure you want to add to
Yes, since Denise is the leader of that program, I'm sure.
Yeah, so I agree with obviously everything that Lorena said. And, you know, I think when someone is told they have prediabetes, it's really a wake-up call, right? I view it as an opportunity. It's something that 20 years ago, we didn't know, right? We didn't really know much about prediabetes. And so you didn't really have that opportunity to intervene. And as you said, Lorena, you know, to start increasing the physical activity, to get rid of those excess pounds. And so, you know, if this was a pill we were handing out and we were telling people, here, take this, and you won't get diabetes, everybody would jump for it. And so, you know, making these lifestyle changes can in fact change your path. I will say that, you know, having met so many people with type 2 diabetes, often I hear from them, you know, my doctor told me some years back that my sugars were higher than normal. And, you know, I didn't do anything about it. I didn't think anything was going to happen to me. And here they are, you know, several years later, and now they have type 2 diabetes. So, you know, that's certainly one of the things I always reinforce with my groups in diabetes prevention, that, you know, it's an opportunity. I think we have to change the mindset, right? Once we change our mindset and how we view information, I think that changes sort of the path and the choices that we make in our lifestyle. And I still get emails, by the way, from many of my participants, you know, who took the diabetes prevention class years ago. And, you know, they'll send me emails and say, guess what? My A1C is still, you know, below the pre-diabetes range, or they've managed to keep it in that pre-diabetes range, which again is a tremendous accomplishment, right?
Yes, Denise, and I just wanted to add a little bit more to that. Some of the studies that I have read is I would say the memory muscle, so to speak, that even after years later of having incorporating these changes, that it remains, and that after years the A1C is still lower. And another piece of good news is that when I say about a 5% weight loss, so we are not talking about major changes. So just to translate that into numbers to make it more real, we are talking about that someone that weighs 200 pounds, a 5% weight loss will be a 10 pounds, 15 pounds. So that's what we are talking about. We're not telling someone that weighs 200 pounds, you need to lose 50 pounds in order to see the outcomes that you want to look for. We're talking about 150 minutes of exercise. So we're talking about 5 days a week, 30 minutes a day. We're not talking about a marathon. Included in the literature for people with type 2 diabetes now, the importance of weight-bearing exercise to manage insulin resistance, and especially simple exercises, including weights. So we are not talking about an hour at the gym 5 days a week, 2 times per week of weight-bearing exercises. So these are simple things that you can do at home using YouTube exercises with certain weights can actually improve your insulin resistance, and that can lower your blood glucose levels. So interrupted seating. So if you're at the computer, like many of us are, and just setting your alarm on your phone so that you can get up and just move for a minute or two can have an impact on your blood glucose. So these are manageable things that all of us can do and have an impact on your blood glucose. So I just wanted to mention that because I think it is important for individuals to hear that little things can actually improve their blood glucose levels.
It was better when TVs didn't have a remote control. Because
Yes, that's when I filed.
yeah,
And that was a long time ago.
long time ago. I don't
Long
think the
time.
youth knows TVs without a remote, but it was actually helpful because you would stand up every so often to switch channels and move around.
And it used to click. Remember, Sandra?
Oh, yeah.
I
Yeah.
don't know if Denise knows that. She looks extremely young to me.
Lorraine, I knew I liked you. And Lorena, I remember when there was only 13 television stations, so that answers that question.
Mhm.
Oh my God, well, I don't even want to tell you that I was a child and we had two, but anyway, I was born and raised in another country, so that also explains the reason why.
Yeah. And we have a comment here. Phones and streaming is making it even worse. And it's true, Michelle. No movement at all. Like you spend just time sitting down and that's about it. And yes, we have a question here. If you have had borderline diabetes for about 10 years, can it turn into full diabetes?
Okay, I couldn't hear you. Can you repeat the question? Sorry.
If you have had borderline diabetes for over 10 years, can it turn into full diabetes?
Yes, it can be turned if you do not manage it well. The misconception is that diabetes is a one-way street to bad health. But truth be told, we can prevent and we can delay complications of diabetes, so we can improve it. So it's not because you're borderline that you're going to become a full person with diabetes. So there is prevention, exercise, medication, and nutrition. So there is control. So it was based on what Lorena said. You can almost reverse it. There are things that you can do, knowing that you're borderline and not take actions to prevent that it becomes full diabetes. That's the key there. If you knowing about something is not enough. You have to apply that knowledge. So if you know that you're borderline, so let's see what we can do to prevent it becoming full-blown person with diabetes.
Mhm. Thank you, Nas. And Denise, as a dietitian, I'm going to direct this question to you because there are a lot of people that I hear that they say, oh no, I cannot eat salt because it's bad for my diabetes.
Yeah, good question. So very often people who have diabetes have high blood pressure or hypertension. And so in those cases, certainly we are talking to people about making some changes, in the choices they make. It doesn't mean they can't use any salt. And in fact, sometimes I'm a fan of, using a little bit of added salt, but getting away from all those processed packaged foods, right? Because that's really where the sodium is, right? A lot of those processed foods like cold cuts or canned soups, a lot of those things that were typical in America back in the day when they were trying to make convenience foods, mac and cheese in a box and hamburger helper. You know, all these things came to be in the US because people went back, mothers went back to work, and you know, they needed to have foods that were fast and quick. And here we are in 2022, and we realize, maybe that wasn't so good. Maybe we need to get back to cooking food, right? Whatever your culture is, we all know how to cook foods within our culture. And so that's probably a better bet. And, you know, using a little bit of salt, I don't think is really the evil. I think it's consuming all of these processed foods. So to answer the question, if you have diabetes, if you have hypertension, which is a very common recipe, we see that often. Yeah, getting towards a healthier eating plan is certainly the way we want to encourage people to move towards.
Mm-hmm. And Denise, what do you think about diet soda? Because a lot of people think that they can drink all the diet soda they want. And I've known people that drink more than 2 liters of diet soda a day, thinking that because it's diet, it's okay for their diabetes.
Right. So, you know, all of these things kind of have to be, I think, taken into conversation with the person, right? And so, example, if I meet someone who has diabetes, newly diagnosed, and they are addicted to Pepsi, regular Pepsi. And, you know, now I start to talk to them about how much sugar is in Pepsi, and they just can't imagine giving up their Pepsi. Well, for that person, we might start changing over from Pepsi to Diet Pepsi. But maybe on subsequent visits, we can start talking about, okay, now that we have changed from regular soda to diet soda, can we think about maybe start replacing one of those diet soda with an alternative beverage? I find often when people are addicted to the carbonation and that fizz, there are so many new flavored seltzers out there that people love them. They just haven't tried them because they got so used to their Pepsi and their Diet Pepsi, or Coke and Diet Coke. But, you know, once they, and I don't go all for none, you know, I might ask them, just see if you can just change one of them a day. Let's see how that goes. And interestingly enough, when they switch out one of those diet sodas for, let's say, one of these new flavored seltzers, they like it. So I think we have to meet people where they are, make those changes along the way. And, you know, ultimately, if we can get people off of diet soda and choosing, you know, healthier beverages, water, infused water, flavored seltzers, teas, you know, all of these things are going to be a much better bet, but it's not going to happen overnight. And I think we need to meet the person where they are and help them sort of make these changes and move forward.
Mm-hmm. Thank you, Denise. I'm going to direct these next 2 questions to Lorena, because one of them has to do with insulin, and no, you're just my insulin person. If a person is taking and has been taking metformin daily at the max dose of 2,000 milligrams per day, is long-term use of metformin dangerous, and would it be safer to move to insulin sooner?
Okay, so those are 2 questions. So with metformin for a long time, the only concern that I would say, first of all, 4 times a day, 500 milligrams, that's 2,000. The highest dose that it's recommended for metformin is 2,500 milligrams per day. That's the highest dose. So you're definitely under the highest dose. When it comes to metformin, for a long period of time, one of the concerns is vitamin B12, that there may be a B12 deficiency. So that's a conversation that you should have with your doctor or healthcare provider to find out about your vitamin B12 status. And when it comes to vitamin B12, the deficiency of B12 can cause anemia. That's one issue. And then the other one are some cognitive problems. And also there can be some tingling in your fingers or extremities, etc. That could be easily remedied. You could be taking a B12 supplement or injections. But the best way to find out if you have deficiency is just by having a blood test where that could be determined. So I would just check first with your doctor or healthcare provider. Is it better to just go on insulin? I would say that that depends on your blood sugar levels. The only way to find out is usually your blood sugar levels. If you're doing well on metformin and there is no need to change the medication, then that is totally fine. When it comes to diabetes management, the medications that you are on, your healthcare provider would see depending on what your blood glucose management looks like and other things that are going on, other comorbidities, or what else is going on. So your kidney health, your heart health, your eye health, all those other things. So there are other medications that can manage your blood sugars, can also protect your heart, protect your kidneys, protect other organs in your body. So based on those things, your doctor determines what medications are best. Sometimes it's also a matter of what your insurance covers as well, because some medications are more expensive than others. So all those things are taken into consideration to find out what is the best medication or group of medications that should be prescribed for you. So that's my answer.
Thank you.
And I don't know if anyone else has anything else to add that I may have missed.
Well, one of the myths that I hear from my patients is, do I have to take it forever? Whether it's insulin or metformin or any medication to treat diabetes, I tell them the same way that you said, discuss with your doctor your concerns, but always keep in mind that our body changes.
Mhm.
And so does the medication. Sometimes you're taking medication for quite a period of time and our bodies no longer tolerate that medication or needs a higher dose or it's not working anymore. So there are options there. But at the basic, I tell them of diabetes treatment is always to make sure that you are eating healthy, you are exercising, and you are taking the medication as prescribed by your doctor. That delays and also prevents complication there. So there's a nice way to go. But again, it could be forever if you're not doing all the other parts there. But it doesn't have to be just metformin. It could be any other medication to control the diabetes, to prevent all the complications there, end up in dialysis, kidney failure, losing a sight, have oral problems, foot problems, amputation, all that comes along if you're not taking the medication as prescribed, or if you think if you're not doing what it needs to do, exercise, medication, nutrition, is a combination, and the things change as our lives changes.
And Eneas, I have another question for you now that I have your attention. Bariatric surgery, is that a cure for diabetes?
My sister have done it, and she has diabetes. It's not a cure, because then bariatric surgery can also cause, in her case, deficiency in vitamin B12. So you might have all those symptoms that Lorena was talking about. But it definitely, you have your nutritionist, your doctor to guide you on the nutrition there. And it can delay the progress. That's what is happening to my sister, but it's not a cure. There is no cure for diabetes yet. This is across the board, across the literature there. So there is management. So losing weight is beneficial, okay? But again, it's not a cure. It's just another way for you to manage your weight um, condition there. No cure.
Yeah, I think sometimes what we hear is remission. And remission, what it means is that you are a certain period of time with a lower A1C, and sometimes you are not taking medications. So people sometimes use cure, but I think the best word may be remission. And when it comes to bariatric surgery and diabetes, the individuals that have a better chance are those individuals that have had diabetes for a shorter period of time. So if you have been diagnosed with diabetes for a year or two and have bariatric surgery, your chances of remission are higher than someone that has had diabetes, let's say, for 10 years and has bariatric surgery. And it also depends that if you have, let's say, the sleeve or gastric bypass has a better chance than a sleeve or than just having the other type. Just now, I just completely forgot the other one, the one that is just restrictive.
Lap band?
The lap band. Sorry for the name, just totally escaped me for the second. Yes, the lap band.
And I warned you that we could talk about this topic forever. So we only have 10 minutes left and we have 3 questions. Denise, your opinion on intermittent fasting and prediabetes, is it beneficial?
Yeah, that's a really good question. And I do get asked that quite often, actually. And so what am I going to say? So let me give you my opinion as a dietitian, nutritionist, diabetes educator. And that is, having done this for over 20 years, everyone that I meet that struggles with their weight, when I ask them, what's your problem time? What's the toughest time of day for you in terms of eating? Most people say to me, after dinner. I'm sitting on the couch, I'm watching TV, and I can consume more during that time. I've had many people say this to me, than I've consumed all day long. And so for people like this, these are often the people who are asking me about trying intermittent fasting. And there's all sorts of different definitions of intermittent fasting. How many hours is it actually? And so for these people who want to try, let's say where their last meal of the day is going to be 6 p.m. at night, their dinner, if they're an early, dinner eater, and they're not going to eat again, let's say until breakfast the next morning, which can be anywhere from 8 o'clock and on, technically that's a form of intermittent fasting. And so I do think that could be valuable for these people who say that their challenging, difficult hour is that they have these behaviors where they eat so much in these evening hours. So I guess my answer to the question would be, I do think intermittent fasting can help. Do I think that everyone needs to do intermittent fasting to prevent prediabetes or diabetes? No, I don't. But I do think that, the more, if you think back to everything we're talking about here today, and that is eating healthy and exercising, anything we can do that will facilitate those behavior changes and make it work for us, then I think that's going to be a win-win situation. So I'm not giving a blanket statement that says, yes, everyone should do this. However, I do think for certain people, it could work. And so that's my answer.
Thank you. And here is another interesting question, Lorena. Myth, doctors might say to a patient, you have prediabetes, stay away from carbs. Then the patient goes to keto or high protein diet without much change to their lifestyle. What do you think of that?
I don't think that I read the question. I don't think that carbs are the enemy. I think the American Diabetes Association certainly has said that there is no specific macronutrient recommendation. So there's no specific carbs, protein, dietary fats that are recommended for people with diabetes or even pre-diabetes. So the diet should be individualized, and they are just dietary patterns that could be given to any specific individual. So I definitely recommend an individualized plan that can work for different individuals. For me, it's all about what I call the P's and Q's. The P stands for portions, the Q for quality. So I would much rather have someone work with a diabetes educator, registered dietitian, in terms of working to focus on quality carbohydrates in the appropriate portions, working to focus on the appropriate portions for satiety, and working on good quality foods that are reasonable for an individual, and working on lifestyle, meaning exercise, including aerobic, and as well as resistance exercise. I think that is what we need, instead of just the diet, focusing on that, so that we can achieve optimal health with diabetes and pre-diabetes. I think that is essential.
Mm-hmm. Thank you, Lorena. And we have one more question that I'm going to direct to Eneas. And in the meantime, I start thinking, because I want to have some closing thoughts from the three of you, or some sort of advice or words of wisdom that you would like to share with our attendees and those who later are going to be watching the recording. Eneas, what's best to take care of your diabetes? An endocrinologist or your primary physician?
I think it's not black and white like that. I think it's important that you have a provider to help you to manage that. And depends on the severity of it, then you can go to a specialist. But if your primary care physician is helping you to manage it and is well managed, there is no need to go further. I would say that. So I do think it's have a provider to help you. Prevention is better than remediation. So that would be the piece of wisdom that I leave you all with. Prevention better than remediation.
Thank you. Denise.
Yeah, my friend with the words of wisdom there. So I'm going to join with my words of wisdom. Listen, I think a healthy lifestyle goes a long way. And if I could give one more plug, that is have a physical, go for a physical and ask about getting your A1C checked. It's a blood test. It's part of the blood panel when you go for a physical. The sooner you know, the more you can intervene and make a change. And that's my words of wisdom.
Lorena?
I say enjoy your food. This sounds like Michael Pollan. Enjoy your food, not too much. Try to buy the best food that you can afford. And I do have to encourage a lot of plant foods because I think that they are best. And as long as it fits into your budget, and then the animal foods, try to get the leanest that you can possibly have, and try to cook as much food as you can in your household, and focus on the activities that you enjoy to do, because then those are the ones that you're going to remain consistent. And that's it. Keep checking with your provider and stay the course. And just try and be less stressed as much as you can, because I think that brings a holistic view of life. So everything affects us. So the stress, the food, and the exercise that we do. I think all of that is important, and sleep as well.
And if I got something right from today, here are my words of wisdom. If you hear pre-diabetes, you know, I'm thinking it's like when you're driving on the highway and the fuel you see is going low. Listen, it's time to stop and put gas in your car if you want to continue on the road. So just the same thing. If you hear the word pre-diabetes, your sugars are going high. Stop, it's time to do something, because we all want to prevent diabetes. I couldn't have a better panel for this. I'm so happy. Thank you so much for sharing your expertise. Thank you for taking care of all those people with diabetes out there, newly diagnosed, old diagnosed. You do amazing work. You do amazing work. And no matter how many times we say that, I don't ever think we say it enough. So thank you so much to our panelists, our diabetes educators, all the healthcare professionals that take care of people with diabetes, because it could be complicated if we don't take care of it. So it's 1 o'clock, time to go. Thank you to our attendees, and I will see you next week. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Thank you, Sandra.
Oh, it's so good to see you, Lori, at least in a screen, you know?
Yes, you're
Great.
still recording?
Yes, let me stop the recording.